This recorded lecture will be going over Chapter 33, the urinary system. The kidneys, ureters, urinary bladder, and urethra are the structures of the urinary system. The kidney consists of the cortex, the medulla, and the renal pelvis. The cortex contains blood vessels and nephrons. The medulla contains the collecting tubules, and the renal pelvis gathers the urine and directs it to the bladder. The nephron is the functional unit of the kidney. There are 1 million nephrons in a kidney. Urine is carried by the ureters from the kidney to the bladder through peristaltic action. The walls of the bladder are smooth muscle called the detrusor muscle that expands to store urine and contracts to expel urine. Blood is brought to the kidney by the renal arteries that branch off the aorta. Blood is returned by veins to the inferior vena cava. The kidneys regulate serum electrolytes by filtration and reabsorption. The glomerular filtration rate, or GFR, is the amount of blood filtered by the glomeruli in a given time. An average GFR is about 125 milliliters per minute. The kidneys regulate fluid volume by filtration, reabsorption, and excretion. The kidneys assist in maintaining acid-base balance by secreting hydrogen ions into the urine. Unwanted substances like urea, creatine, and uric acid will all be retained in the tubules along with some water. Approximately 200 liters of liquid are filtered in a 24-hour period. Then 1.5 to 2 liters are excreted as urine. The kidneys regulate blood pressure by secreting the enzyme renin. The kidneys increase red blood cell production by secreting erythropoietin. In response to low blood flow to the kidney, the juxtaglomerular cells release renin, which joins with angiotensin to form angiotensin I. Angiotensin converting enzyme produced by the lungs will change angiotensin I to angiotensin II. Angiotensin II causes peripheral vasoconstriction, resulting in more blood flow to the kidney. Antidiuretic hormone, or ADH, is released from the pituitary gland when fluid volume is low. It causes the kidney to conserve water. When adequate circulating volume is present, ADH is not released. On page 792 within Table 33.1, you can look over some hormones and their metabolic actions associated with kidney function. The bladder holds the urine. The normal capacity is 300 to 400 milliliters. Maximum capacity could reach 1,000 to 1,800 milliliters. The micturition, or voiding reflex, is initiated and transmitted to the bladder. Urine passes from the bladder through the urethra during urination, also known as voiding. With age, in men, the prostate gland will hypertrophy and can cause varying degrees of obstruction to the normal flow of urine. Secretion of renin and aldosterone and vitamin D activation are decreased. Degenerative changes in the bladder muscles can lead to residual urine and urinary incontinence. A decreased ability to concentrate urine leads to nocturia. Problems in the heart, lung, or circulatory system can arise from kidney disorders or kidney failure. These images can be seen on page 791. The high volume of blood that is filtered by the kidney contains some bacteria. These bacteria can colonize the kidney, causing an infection. When an immune reaction occurs in the body, the glomeruli that filter the blood are exposed to antibodies and antigen-antibody complexes contained in that blood. These antibodies and antigen-antibody complexes can cause an autoimmune inflammatory reaction known as glomerulonephritis that will damage the semipermeable glomerular membrane and interferes with normal kidney function. Tumors can form in the bladder, ureters, or kidney and interfere with normal function by altering cell structure or impeding urine flow. Tubular necrosis can be caused by a lack of oxygen or bacterial or chemical destruction of cells, which affects the functional ability of the nephron and decreases kidney function. Hypertension is a major cause of end-stage renal disease. Conversely, renal disorders could also cause secondary hypertension. Because so much of the kidney's function is directly related to the capillaries and arterioles, any disorder like atherosclerosis and diabetes mellitus that systemically affects the blood vessels can affect the kidneys. When these vessels become sclerosed, blood flow through the kidney is decreased. Kidney function diminishes, and eventually this will lead to chronic renal failure. One of the best ways to prevent disorders of the urologic system is to drink an adequate amount of water. A minimum fluid intake of 2,000 to 3,000 milliliters per day is recommended to initiate good flow through the system. A healthful diet, exercise, and not smoking will also promote urinary health. On page 793, see the green health promotion box. You can promote bladder and urinary tract health by encouraging patients to empty the bladder sooner rather than waiting to urinate. Emptying the bladder will prevent urinary stasis and prolonged exposure of waste toxins on the bladder wall. This can contribute to cancer of the bladder. Delayed voiding will also cause the bladder wall to stretch beyond normal capacity and places undue strain on the sphincters. Both of these can contribute to urinary incontinence later in life. Controlling blood pressure and maintaining a normal serum glucose level can help support healthy blood vessels. When drugs that can be harmful to the kidney, like sulfa compounds, are prescribed, increasing the fluid intake to 3,000 or 3,500 milliliters per day will reduce the risk of kidney dysfunction. Increasing fluid intake must be carefully considered when the patient has other conditions, like CHF or cirrhosis of the liver. On page 793 within box 33.1, you can also see some examples of potentially nephrotoxic substances. Patients experiencing problems with the urinary system will undergo urine tests, like a urinalysis and culture and sensitivity, as well as blood tests such as a CBC, blood urea nitrogen, serum creatinine, and creatinine clearance. Urea is produced when proteins break down. It then combines with ammonia and is carried by the bloodstream to the kidneys for excretion. BUN and serum creatinine are interpreted together, and lab values should be obtained before the use of radiologic contrast dyes. Creatinine clearance is a good measure of GFR. Radiologic procedures will range from a single view of the kidneys, ureters, and bladder, such as a KUB, to interventional radiology, like a balloon angioplasty. Urodynamic tests, such as cystomatography, can be used to measure flow volume and muscle function. Biopsies of the kidney or bladder are done in combination with radiologic examinations to locate lesions. On page 795 through page 798, you can see some diagnostic tests for urologic disorders. General nursing responsibilities for all diagnostic testing include assessing for allergies to contrast media, verifying that a signed consent is present when indicated, and ruling out pregnancy before radiologic procedures and scans. This image can be seen on page 794. Many substances can be toxic to the kidneys, known as nephrotoxic. You should obtain a patient history that includes the use of prescription and over-the-counter drugs or any illicit substances, as well as any occupational exposure to hazardous materials. Nursing responsibilities in the daily assessment of urinary function include measuring intake and output, evaluating abnormal flow of urine, noting the character of the urine, noticing changes in the pattern of voiding, and assessing pain and discomfort. Documentation includes objective observations of the amount and characteristics of urine and the patient's subjective reports of pain, discomfort, and any abnormalities. The color of urine can give helpful information about the status of the patient and their functioning kidneys. Another characteristic that should be noted is odor. Normal urine will develop an ammonia-like odor after it has stood for a length of time, but this odor should not be present in freshly voided urine. A foul smell can indicate infection. Hematuria means blood in the urine. Gross hematuria is a sign of bleeding from some point in the urinary tract. If the blood has been in the bladder or kidney for a long time, it will deteriorate and cause the urine to be a smoky gray or dark brown. If the blood is noticed as soon as voiding starts, it is likely that the blood is from somewhere in the urethra. Proteinuria is the abnormal presence of protein in the urine. Proteins are too large to pass through the structure of the glomerular membrane. Therefore, the presence of protein is suggestive of damage to the membrane that occurs in renal disease, like nephrotic syndrome or glomerulonephritis. Specialized assays will be required to detect microalbuminuria. This is the presence of albumin in the urine, and it is suggestive of early kidney disease. Pneumaturia means gas in the urine. This can occur if there is a fistula between the bladder and the bowel or vagina. Ask about or observe urinary frequency during the day and night. Other alterations include the size and the force of the urinary stream, a feeling of fullness even after voiding, and change in the amount urinated each time. Caffeine and other diuretics found in foods and drinks, and an increased intake of fluid can all increase the number of times a person must urinate. Bladder pain can be caused by the stretching of an overfull bladder. If a smooth, rounded mass is felt on palpation in the area above the pubic bone, the bladder is distended. Bladder pain can also be caused by spasms of the bladder musculature as it attempts to empty itself of clots, bits of tissue, and other cellular debris. Flank pain, which can occur in the side and back area of the body, below the ribs and above the hips, could be caused by obstruction and distension. In this case, the affected organs will be the ureters and the kidney pelvis. When evaluating flank pain, note the location and assess for any radiation of pain from the kidney or ureter to the genitalia and the thigh. Dysuria is usually caused by inflammation in either the bladder or the urethra. It is often described as a burning and can range from mild to severe. Ask the patient when the pain occurs and whether it is felt immediately before, during, or after voiding. On page 800 within table 33.3, you can read about some common causes of variations in color in the urine. And on page 801 within box 33.2, you can read about the terminology related to urine output and flow. Fatigue and irritability are common when kidney function is impaired due to the buildup of waste products in the body and their effect on body cells. Caring for patients with urologic problems includes monitoring intake and output, body weight, and signs of edema. Monitoring drug combinations for potential nephrotoxicity and for possible urinary retention is also very important. You must use strict aseptic technique when catheterizing patients, emptying drainage bags, handling drainage tubes and stents, and performing peritoneal dialysis or hemodialysis. The catheter should be fastened to the upper leg with a tape or catheter securing device. Irrigation of the bladder is not recommended unless there is an obstruction or a special solution needs to be instilled. If open irrigation is performed, strict asepsis must be maintained. Patients with urologic disorders are very likely to suffer fluid imbalances, and therefore their intake and output should be measured and the totals recorded every 8 to 12 hours during hospitalization or acute illness. Urine output should be at least 30 mL per hour. For total output, measure all of the urine excreted, drainage from all tubes, any emesis, and watery tubes. On page 803 within box 33.3, you can read about some principles of urinary catheter and tube care. And this image can be seen on page 802. Compare intake and output data over time to determine clinical improvement or the presence of problems. Laboratory data like BUN, creatinine, potassium, and urinalysis results will provide further information to evaluate the effectiveness of treatment. A large percentage of residents in nursing homes are incontinent, and it is the leading cause of admission to a long-term care facility. Women who have had several children may have anatomic changes that make incontinence more likely. Men may experience the problem due to an enlarged prostate. Other contributing factors include spinal cord injury, neurologic disorder, or functional disorder. The first step in managing incontinence is to identify the factors that could be contributing to the problem. Urine flow out of the bladder is controlled by two circular muscles called sphincters. Many factors can cause loss of sphincter control. Unconsciousness, UTI, paralysis, interference with nerve transmission to and from the brain, and a loss of muscle tone of the bladder and sphincters are some of the common causes of incontinence. There are several types of incontinence: urge, stress, mixed, overflow, functional, or neurologic. Urge incontinence is the involuntary loss of urine when there is a strong urge to urinate. Stress incontinence occurs when the urethral sphincter fails and there is an increase in intra-abdominal pressure, caused by things like sneezing, laughing, coughing, or aerobic exercise. Mixed incontinence is a combination of different types, like stress and urge incontinence. Overflow incontinence occurs when there is poor contractility of the detrusor muscle or obstruction of the urethra, as in prostate hypertrophy in the male or genital prolapse in the female. Functional incontinence is caused by a cognitive inability to recognize the urge to urinate or a self-care deficit caused by extreme depression. Inability to reach the bathroom due to restraints, side rails, or an out-of-reach walker could also result in functional incontinence. Neurologic incontinence is caused by disorders of the neurologic system, like multiple sclerosis or a spinal cord injury. Unintended excretion of urine is the primary symptom. Diagnosis of incontinence is based on a careful history, and the patient must be able to report symptoms accurately. When conservative measures do not improve continence, the healthcare provider may choose to evaluate the condition with a series of diagnostic tests, including measuring the post-void residual volume, stress testing, urodynamic studies, cystogram, or cytoscopy. Evidence-based practice indicates that stress incontinence that occurs with exercise, laughing, or coughing can be corrected with exercises to strengthen the pelvic floor muscles. Kegel exercises benefit men as well as women. Vaginal weight training with a set of 5 small, cone-shaped weights that are used along with pelvic muscle exercise is another therapeutic option for incontinence. The lightest cone, which has a string attached, should be inserted into the vagina and held in place by muscle tightening for 15 minutes twice a day. Various medications have been found to be helpful in treating incontinence. Table 33.5 will provide additional information about selected drugs for urinary incontinence. A pessary, a stiff ring that is worn in the vagina during the day to support the bladder, can be used as an assistive device to support the pelvic floor when treating vaginal prolapse and urinary incontinence. Further treatment options for urinary incontinence include biofeedback therapy or an implanted sacral nerve electrical stimulation device used for the treatment of an overactive bladder. A variety of procedures can be performed to correct the anatomic position of the bladder by supporting the urethra. These surgeries are most often performed to correct urinary incontinence in women. An artificial sphincter implant is used in males to treat incontinence after a prostatectomy. When these measures do not solve the problem, incontinence can be managed by intermittent catheterization, indwelling urethral catheterization, a suprapubic catheter, an external collection system, like a condom catheter or female external urine management system, and protective pads and garments. Use a gentle and matter-of-fact approach when taking an incontinence history. Observe the clothing for stains and odors and perform a general physical assessment, including the palpation of the bladder. When incontinence is not remedied by correcting an underlying cause, attempt to help the patient by setting up a voiding and fluid schedule. Getting the patient on a voiding schedule will take a great deal of patience and persistence on the part of you and the patient. Accidents will happen during the retraining period, and patients need to be assured that this is expected. Any bleeding, dribbling, or incontinence of urine or inability to void within 4 to 6 hours after removal of the catheter should be reported to the healthcare provider. Urinary retention is retaining or holding urine in the bladder. It can be acute after a surgical procedure, after removal of an indwelling catheter, or with certain medications. Or it could be a chronic condition related to anxiety, neurologic disorders, or obstruction of urine flow through the urethra, as in enlargement of the prostate gland. Retention of urine will stretch the bladder walls, causing extreme discomfort. Bladder scanning can provide better data. A caffeinated drink followed by a warm bath can help. Instruct the patient to double void. This means voiding, sitting on the toilet for several minutes, and then voiding again. A medication for urinary retention is bethanechol or uralcholine. Poor bladder tone or partial obstruction of the urethra can result in dribbling of urine or passing only the overflow, leaving the bladder potentially full. During bladder retraining, residual urine can be measured by having the patient void as much urine as possible and then performing a bladder scan or immediately inserting a catheter. 100 milliliters is considered a normal amount of residual urine. Any amount more than that can become stagnant and concentrated over time, predisposing the patient to bladder infection and the formation of stones.